They hired me for a reason. Oh, sometimes. Oh, they did. The pillow did.
Google Translate video and it came up to German Sorge. Is that
Yes,
how you
great.
say it? Oh,
Yes,
okay.
yes. And then there is N, so you are great. This is Polish letter. N with this
Okay.
Polish letter.
Okay. I didn't know how to pronounce it. I tried Persian as well, but I couldn't say hello in Persian. How do you say hello in Persian?
We
Today.
say durud.
Durut.
Yes.
Okay, it's not spelled like Durut. It's like yeah, I couldn't figure it out. And there's so many accents.
Malay languages in
India.
India. I speak Malayalam. It's not so popular language, a small state. So,
How do I say good day?
hello, like namaskaram, namaskaram,
Namaskar.
namaskaram, like namaste.
Namaskara.
Oh yeah, namaskaram. Yeah,
Okay, I'll have to write it down to remember it.
that's okay. Anjana, it was a really good presentation.
I think it was very boring for the optics people.
No, it was like
It
something
was amazing. That was so
Yeah.
something we knew.
I thought I could put the, because we've done quite a lot in terms of we've done JPC. So I could have put the refraction and the optics power space to show I can do that. But then I decided no, there's no time.
It was quite interesting to know what the whole process about. It was not something I thought about.
Yes.
You know.
Yeah,
Yeah.
so it's
Hearing
nice.
fed people.
My husband says it's like talking about the color of bubble gum at a mathematics convention. He wants to know what VPO stands for, and I said no. He said, "Is it for very poor optometrists?" So I said, almost. It's not private practitioners. So very poor optometrist is not that.
the same presentation of Josh about this eye that was waking up between optics about these eyes of this animal. It was so amazing. Because Albert. And
I wanted to
amazing
say,
presentation. Just
a fun
and
thing.
I wanted to say that horses, they are hyperopic. My students now measure horses.
Okay.
Yes, they are have to plus two dioptries of being
+2.
This thing about horses that I read somewhere about their retina is almost a ram-like retina, so that they don't have to accommodate by tilting their head. Is that true?
I don't know because he's starting now
Okay.
with measuring of that. So in 3 months I will be more educated.
But I also want to say giraffes apparently have the largest retina.
Okay.
Because they've got quite thick eyes, but their little head. Giraffes got the biggest retina.
They have also
The biggest eyeball.
the biggest reservoir.
Okay, that's why they've got the
Creatures live
biggest.
down.
That's why they've got
Very
the
small gauge.
There might have been some dinosaur with bigger pads.
Really small. So it's not.
the biggest eyes. Well, that's why they've got the biggest retina. Yeah. Okay.
Or you could go to the airport.
Suddenly.
No.
Do you know what no, it is best.
That is a very nice. Let's take your baby quite seriously.
It's the best.
Yeah, when I'm on the Shrek, I was expecting him to. This is what. Yes.
And everyone watches lips. I started watching lips just you guys.
We are smacking.
How do you guys
Smacking.
so in the movie, for example, if they see someone with MGD, they would start all
What is amazing is that we think these products are common to South Africa. But as you've mentioned, the Choma, something from Mexico. It's a set. And ophthalmology still remains the biggest issue.
+2. More or less +2.
Because what I can find from the literature is 0.3. About 0.3.
Yes. But because they are
Just taken from the peak.
but I think it also depends on the stresses.
It does depend on
On methods of
how it's prepared.
On the right.
It's something
Yeah.
from
We do retinoscopy.
something from the surface.
Right.
My students try stuff. It's minus 80. Is that true?
Okay, so next up is Adam Choma. He is a master's student at the University of Johannesburg and a staff member at the University of Limpopo, where it gets nice and hot. And he will be talking to us about Meibomian gland dysfunction and ocular surface profile in keratoconus patients attending a South African-based clinic.
Thank you very much. Greetings, everyone. As Dr. Evans has already introduced me, I'll be speaking about movement and dysfunction and ocular surface profile in keratoconic patients. Just to give a bit of background, there's no optics or mathematics or all those complicated formulas there. It's just clinical experiment. So when we were students, all we did is contact lens in fourth year and would fit contact lenses in keratoconic patients. And the most common thing that we encountered was that almost 90% of those patients, they would be rubbing their eyes. And our advice to them will always be, can you please stop your eyes, rubbing your eyes? But we never actually told them what they should do when those eyes becomes itchy. And they would always ask that questions, or if my eyes are itchy, what should I do? And as a student, you don't necessarily have any answer to that. So I took it an initiative for me to actually conduct a study to find out what is the reason why those patients rub their eyes. Hence, you can see that it's my topic is Meibomian dysfunction and ocular surface profiling in those keratoconus patients. So just to give a bit of background or definitions, we all know that keratoconus is a progressive conditions that and eyes becomes a cone-like and the cornea's thickness becomes more thinner than it should be. And Meibomian glands, they are glands that secretes the lipid layer of the tears, which is the layer that prevents evaporation, or the first layer of the tear film. And Meibomian gland dysfunction will be the dysfunction of those glands that actually secretes the lipid layer. Just to show you on pictures where we find Meibomian glands, they are actually found under the lids, either the upper one or the lower one. So those lines that you're seeing there, those will be Meibomian glands, and they will secrete the lipid layer somewhere around here, where the lid starts here. So those will be the glands, and those will be the glands openings. And then keratoconus will be the bulging forward of the cornea, and the cornea will also become thin. Just to give you a background again, that Meibomian gland and dry eye disease, they are the leading cause of eye irritation. That answers the question of why were those patients actually rubbing their eyes. They were rubbing their eyes because of Meibomian gland dysfunction, or to be specific, dry eye disease. There are so many things that can cause the patients to rub their eyes, but those were the leading ones. And although we know that the gland dysfunction can affect the ocular surface, we also have to investigate the prevalence in the keratoconic patients. As I've already mentioned, that those patients, 90% of them will be rubbing their eyes. So hence, we need to actually investigate how prevalent is that in the keratoconic patients. So the gap was that we need to investigate the prevalence of Meibomian gland dysfunction in those keratoconic patients, more specifically in South Africa, because most studies that I've read or reviewed, they actually do investigate the Meibomian, but in different countries, more especially or mostly in Europe and China, they actually investigate a lot of Meibomian dysfunctions. And the importance of that is that it will help us manage those patients. As I mentioned, that they would ask us, what should I do? But if we don't know the cause why they are rubbing their eyes, then it would be difficult to actually advise them, okay, you can go and buy eye drops that actually have that lipid layer of the tears, then it will reduce the symptoms that they're experiencing. And then my objective for this study was that I need to assess the prevalence of the Meibomian gland dysfunction in those keratoconic patients. And because of me encountering those patients that actually rub their eyes, I came up with an hypothesis that in those patients that has keratoconus, I'm probably going to find a higher Meibomian gland dysfunction. And I'm also going to find that they also have dry eye disease. So hence I came up with this hypothesis there. And as I've already mentioned, my study aim is that we need to investigate Meibomian gland dysfunction and dry eye disease in those patients that have keratoconus and compare it to patients that don't have keratoconus and actually see what's the difference between the two groups. So our first main objective was that we need to compare the two groups, that in the keratoconic patients, how is their Meibomian gland, and in the control group, how is their Meibomian gland, and also encounter or characterize the ocular surface, meaning we need to check what actually those Meibomian gland cause on the keratoconic, on the ocular surface. Hence, we are also characterizing the ocular surface status using clinical tests and questionnaires that I'll come to later on. And then we also have to identify the implication of patient care and early detection. That will actually help in managing those patients. And my study happened at University of Johannesburg, optometry clinic, and I collected my study from June 2023 to June 2024 at the university clinic. And then I had 40 keratoconus patients and 40 control participants that actually took part in the study. And initially, because due to ethical clearance and due to ethical rules, I needed them to be older than 18 so that they can give me consent to actually conduct the study. And looking at the age range of our patients, we see a lot of patients up to the age of 70. Hence, my age range is from 18 years to 70 years of age. And just to mention that the test that I mentioned, or the test that I did, was the tear film examination, Meibomiography, and having to grade those Meibomian gland dysfunction. And this OSDI is a questionnaire that is standardized that we can use to actually read the patient's symptoms of dry eye. So methods and clinical assessments. So this is the test that we did, an non-invasive tear breakup time using an ocular keratograph. So with this one, how we do it is that the keratograph actually takes the measurements for you. So the patient will just sit behind the keratograph, and then the keratograph will measure how long does it take for the ocular surface, or to be specific, the lipid layer to break. And your tear meniscus height measures the amount of tears. Basically, they are there in the lower phonics of the patient's eye. And we also use the keratograph because we take the picture of the patient's lower phonics, then use the keratograph to measure the amount of tears inside that lower phonics. And ocular surface staining, we use two dyes, which is fluorescein and lissamine green. The fluorescein one, we use the to dye or to stain the cornea, and the fluorescein, the lissamine one, we used to stain the sclera or the conjunctiva on the sclera. And we also use OSS grading scale to scale. How we do this is that we stain the cornea and the conjunctiva, then we count the amount of dots that are on the cornea or on the sclera. Then we use the OSS grading scale to actually grade that. With mammography, we used the slit lamp or biomicroscope to invert the eyelids. Then we take the picture of the eyelids. Then the biomicroscopy will measure the amount of glands that are lost and the amount of glands that are remaining on that eyelids. And as I mentioned, that the OSPI is the questionnaire that we give it to the patient answer or rate the symptoms that they're experiencing on their ocular surface. And just some of the inclusion or exclusion criteria that we used. We made sure that in our inclusion criteria, we just to control the bit of those people that or those participants that will take part in the study, we made sure that those patients for the keratoconic group, they have to have been diagnosed first with keratoconus. And for our healthy individuals, we made sure that they don't have any ocular pathologies that we know of or that the patients knows of. And for our exclusion criteria, we excluded everyone that had surgery in the last 6 months or that have any active ocular inflammation. And we also made sure that those patients haven't worn any contact lens in the last 48 hours. And now we go into our results. The people that actually took part in our study, there was 80 people, 40 keratoconus, and 40 control groups, just to make the numbers equal. And in our study overall, we had 55% of females and 45% of males. So it was mostly skewed to the females. And our average age for the keratoconus patients, we had a lot of older people mixed with the younger ones. But for my control group, the age gap was, or the age average was around 20 years, because mostly the people that participated or took part in my study for the control group were mostly students, some of the patients, but mostly it was students in the 3rd year, 4th year. So the average age was 20 years. Okay, so for my data analysis, I used SPSS version 14.0.1, thanks to Prof. Allen here, who taught me how to use or how to get my way around it. And we did comparison studies where we compared the means of those values, and we also did where we checked the relationship between keratoconus patients that experience dry eye and also the control group gland dysfunction and dry eye. And we also check if there's any significance between those two groups. Just to summarize my data, if you look at here, we have keratoconus patients, and then this side we have control participants, and both of them we use their right and left eye. So remember, we had 40 patients this side and 40 patients this side. So for our non-invasive tear breakup time, we have for the keratoconus patient, if you notice that the values are 13.23 and 13.26 this side, whereas in the control groups, they're much higher than that, which is 16.61 and 15.87. So what this means is that for keratoconic patients, the lipid layer of the tear film takes lesser time to actually break than in the control participant. So meaning the quality of the lipid layer, that is the layer that is secreted by the Meibomian glands, it's not so good than in the control group. So the norm here, they probably range around 25 to 30 seconds for the non-invasive tear breakup time. But if you notice this one, they are also experiencing those dry eye, but not as bad as in the keratoconic participants. So our tear meniscus height also ranges to 0.25 millimeters, and that's the norm. So if you notice in the keratoconus patients, it's 0.15 and 0.15, but whereas in the control participant is much higher than that or closer to the norm, which is 0.25, 0.21, 0.21. Also with our OSDI, this is the questionnaire that they use to actually rate the symptoms that they experience or dry eye symptoms that they experience. So this is out of 100, meaning it's more or less in percentage. So there are keratoconic patients, they're more closer or they have higher percentage, meaning they experience more symptoms of dry eye than our control participants. And then this is a keratoconic stage rating or grading. So if you notice that most of the keratoconic participants, their stages ranges around 2.7 or 2.70, 2.75, which shows that their severity of the keratoconic is a bit higher. Whereas in here, we mentioned that these patients or these participants did not have any keratoconus, hence their stage is 0. And then for the ocular surface staining, this is out of 12. And if you notice that in the keratoconic participants, we have 7.5, which is closer to 12 than in the control participants. And lastly, this is the Meibomian gland dysfunction. It's also a grading scale that we use. And if you notice that Meibomian gland dysfunction here, they are much higher in the keratoconic participants than in the control participants. So just to show you pictures of how the X-ray biomicroscope works is that you invert the lid, then you take a picture of the eyelids. Then it will tell you what did you take the measurements, gland percentage and gland loss, and if it's grade what. So it grades 0 here because there was 100% gland and 0% gland loss. In this eye, if you notice that we have 26% gland, and then we have 56% of gland loss, which is grading it as grade 2. One thing that I need to say that is that the software is not really that developed. If there is some areas that it couldn't analyze, it wouldn't tell. If you notice that we have 26 and 56, but they don't add up to 100. So the other remaining is that the software couldn't actually analyze that area if there's claims or there's not claims. Now, my key findings or the findings that I got in this study is that in the keratoconic participants, compared to the controlled, they have reduced tear film stability, which is indicated from the lower non-invasive tear breakup time. They also have decreased tear volume, which is indicated by the lower tear meniscus height. And then they have higher OSDI score, which is indicative that they have higher or they experience more symptoms of dry eye. And although our study was not that perfect, it had some limitations. Is that all we did was that we did a cross-sectional design limits for casual interference. What this means is that we only did those measurements like one time and then we let those patients go. We never followed up if anything changes or anything is happening. Another thing is that some of the environmental factors or some of the environmental influences were never controlled. We never knew where those patients live, whether they live at high humidity places or lower humidity places. Also, our sample size was relatively small because I only used one institution or one clinic there, to be specific, at the University of Johannesburg. And Another thing is that the age variations between the keratoconus patients and the control participants was not fair, because most of the participants in the control were very young than in the keratoconus participants. Okay, so now my conclusion is that this the significance association between keratoconus and dry eye or Meibomian gland dysfunction, and also there is a need to perform longitudinal studies that will actually make us assess the ocular surface more properly in those patients, or to see how does the progression of Meibomian gland or of keratoconus affect the Meibomian gland dysfunction. And lastly, I just need to acknowledge my supervisor, which is Dr. Elizabeth Chetty, and the University of Johannesburg Department of Optometry staff and students for taking part in my studies. And yeah, that's the end of my presentation. Thank you. I'm ready to ask any simple questions. Okay, we'll start here.
Thank you so much for the awesome presentation. So I'm not sure if I missed the average age for your keratoconus patients. I know the one for the control group, I think, was like 20 years for keratoconus patients. So also, okay, the follow-up question is, the reason why you took, because you mentioned that you see like 18 years to 70 years in the clinic, but you only chose like 20, 26. Was it because from the knowledge that I have from the literature, that there's some changes in the Meibomian gland with aging, and also the destabilization and thinning of the lipid layer as people grow older? Is it because you took account of that, or it was just convenient sampling of what you had in the university?
Oh no, I never took into place. As I've mentioned, that my age range that I needed everyone to participate was from 18 to 70 years of age. But because I never had control of who comes to the clinic, hence I just took everyone who was there. And at the end of the study, when I calculated my age range, it turns out that it was extremely lower than how I expected. Maybe you'll find that we have 150 years old, 120 years old, 120 years old, and a lot of 18, or a lot of, yeah, it just depends on who came to the clinic. Any questions?
Okay, thanks for the presentation. I'm not so sure. There's one slide that you have passed. I think the second one. Yeah, no, go back a bit. Back. No. Let's start on where. I think the second. Next one. Next. Oh, next. There's one with a table that is showing. Yeah, there's one. Did you do the study, or you took the record? Unless it's you who made a mistake. Retro. And then on the other one, as for the presentation, it was fine with you, but for the analysis, when you present that, you are bringing both eyes, and the results are different, but it's one person. And now you see it brings something, and whether you are supposed to correlate the two, because it's one person, but this one person is even different. And hence, it's one person with two eyes, then whether I correlate the two to be for one person or one eye.
Oh, thank you. Yes, it's two person. It's one person, but there's two eyes, and the severity of the dry eye in the both eyes are not always the same. even the severity of keratoconus in both eyes, they are not always the same. Hence, they have different results. I don't know if that answers your question. Any other simple question? Thank you.
Technical questions can be the toughest.
Exactly, that's true. And my question would be, I think, similar. Did you compare the eyes of people with keratoconus? But you know, sometimes you see only keratoconus on one eye, on the other there you can see it, at least now, for example, for a few years, yeah. But is there a difference with these parameters for the same person, but you know, one eye with keratoconus, another without?
Yes, that's a very brilliant question. Yes, there were, just that here I did not present my raw data, but there were quite few people that the severity of keratoconus in one eye is not similar to the other, or other people where the keratoconus only is in one eye. But we also took both eyes, and we also took measurements in both eyes and graded both eyes in them. So you find that in one eye they are grade 1 of keratoconus, but on the other eye it's grade 0 of keratoconus.
Okay, and in this situation, was a big difference for these parameters?
Yes, they were different in terms of, you find that the eye that is grade 2 has lower, let's just say, tear meniscus height, and on the other eye that has grade 0 has a much higher tear meniscus height. So the results were different.
Yeah. So for the healthy eye, it was like in the control group.
Yes, that's right. In the healthy eye is more similar to the control group than the keratoconus group. Any questions? Oh, thank you.
Next, Magdalena will be introducing us to ocular biomechanics.
Thank you, Tanya. Sorry, I have to drink it to try for me. Okay, I have so forward. Yes, I have to, okay. So in the program, you have the introduction to biomechanics, but actually I think that it will be more general lecture than introduction. So just I will start from some retrospection. When Tanya asked me to give lecture on biomechanics, I was in panic because it was just 3 weeks ago, that I will have not enough time. But later I thought, wow, because 22 years ago, when I was at Mopane conference, I was only the one who had lecture about biomechanics. This time I was PhD student, so I was a little bit scared that it's no sense in this biomechanics. Everybody talk about operations, and still we talk about operations. It's definitely very important field of the research. But after this 22 years ago, biomechanics became very important field of the science research connected with ophthalmology. So during my lecture, I would like to show why we need this knowledge, why it's important, and what benefit will be for the people and for clinical use. So let's start from a simple definition. Biomechanics is science that deals with the origin and the effects of forces that act on the living organisms at the molecular, cellular, tissue, and organ levels. And actually, according to the ocular biomechanics, we used to work on the tissue and organ levels, and these examples I will present. So biomechanics mainly is associated with the skeletal muscular system in use of sport biomechanics, work biomechanics, joint implants, and this knowledge have been developed over the years. Over the years. So in this respect, ocular biomechanics is quite a new field of science, even that it's 22 years, my 22 years. So ocular biomechanics requires numerical models. So we construct models. We want them to be as realistic as it's possible. We want to avoid simplification, but from another hand, we have to start somewhere. And we have to remember about functions of the eye. And the most important function of the eye, which can't be overlooked, is vision. And these models, we need to improve understanding of ocular components, which are very difficult to measure in clinical practice, simulate ocular physiology, functions, dynamics, to model aging processes of the eye is a very important point of this research, because we can predict what will happen with the eye after some surgery, after some treatment. It's benefit for patients, and as Justice Hosnell mentioned, each eye is unique. So these material properties change with age, and numerical models, it's one of the two, but I think that even one which allow for this kind of prediction. We will support clinical diagnosis with this model the optical system of the eye, and predict surgical and therapeutic outcomes. So for construction of this numerical models of the eye, mostly we use finite element methods. And we have to start with something. So we have to include in that geometry of the elements of the eye, which are very difficult. Shapes are asymmetric. Thicknesses are not constant even in elements. So it's difficult even to join these elements of the eye in the model, because we have the bending movements to join in the point when we joined it, and a lot of geometrical linearity. Boundary conditions, fixation in the literature, it's no standard for the fixation of the model. Sometimes it's 1 point, sometimes the back hemisphere it's fixed. It depends actually from the application of this model. Tissue properties, it's the biggest, I think, problem, because in case of the eye, it's even impossible to measure in vivo, We have the ex vivo experiments, sometimes histopathological experiments, but post-mortem, all this tissue lost the material properties. So still it's some kind of simplifications. Material model, mechanical behaviors, which we want to include in this model. We have a lot of different models which we can use, and we have to pick one. So we need some validation of the model. I will mention about that, which is difficult to find a way to validate the model. And discretization of the model element, type element, size, division method, and finite element solution option. The software for finite element analysis will suggest us some solutions or position to all these points, but we have to have some knowledge at the beginning to control errors during this during the solution, because we have some simplification, of course. And general view for ocular biomechanics. So in literature, we can find the model of the whole eye, which mostly don't include any details of the eye, which support ophthalmological diagnosis, disease progression, and improves therapy and new treatment or surgery, which will be proposed for ophthalmological use. Corneal biomechanics, mostly to investigate the corneal ectasis as keratoconus. It's very important part of the research, development, and classification of refractive surgery. Actually, it's just examples of use for corneal biomechanics. Biomechanics of ocular shell, glaucoma diseases, and diagnostic. And according to that, development of tonometric methods, because still they are not perfect. And its simulation of Goldman tonometry is the half of the model. So it's cornea and sclera. And during the applanation of the center part of the cornea, not only cornea take place in this process, but sclera as well. So it's surprising, maybe for ophthalmologists, but from the mechanical point of view, of course, it makes sense. We know that should be like that. RF tonometry, I will show later the examples for this modeling. It's more dynamic measurement of the intraocular pressure, and of course modeling of the eye optical system. And nowadays we have the increase of studies connected with the biomechanical parameters of the sclera, which are crucial to assess the risk of myopia and progression of myopia. And I think that it will be the future for mechanical biomarkers according to the eye. And here is in the corneal angle biomechanics, again, diagnosis, ocular block diagnosis, and modeling of the iris, just to check behavior of this tissue when we observe increasing of intraocular pressure. So it's important in glaucoma. And lens biomechanics, mostly connected with studies of accommodation, cataract diagnosis and surgery, and intraocular lenses simulation, and Jorge shows some example of modeling of the lens. So at this point, I want to finish this general overlook on ocular biomechanics and move to physiology, from which the biomechanics result. Oh, sorry, I forgot about retina. So after this point, I will move to physiology. So retina, optic disc, lamina crepitiosa, biomechanics, again, glaucoma and age macular degeneration diagnosis. So we have the general models, but more details as well, where lamina crepitiosa is this crucial, very soft tissue, important in glaucoma. And the vitreous biomechanics, most unknown part of the eye, but important as well. So diagnosis of retinal detachment, and now developed of methods for drug delivery to the eye. But the best option will be, because all the time we need some simplification, to have the model of the old school with 2 eye sockets, with 2 eyes, and very close to reality. I don't have this model. Actually, it's our simulation, but to this time, it's impossible to model everything. And probably in short time, I will have rather not. Okay, so physiology. Ocular dynamics, because it's connected with biomechanics. What is involved? Optical parameters of the eye and cornea, I determined it here as aberration, of course, and Ray mentioned that even it changed with time during the blinking, but as well change with different signals from our body. And the signals which were changed, which change the biometry, is electrocardiography, blood pulsation, and breathing rate. And the signal change with time as optical parameters. So when we will move on the frequency, this signals will be very similar. Okay, so it's dynamic of the eye. And cornea, in many models, it's treated as, in the modeling of the optical system as well, it's treated as the static element. But in fact, it experiences the movements, let's say horizontal for this figure, horizontal movements, which are connected to pulsating of the IOP. It's very rapid system, which are influenced by pulsation of the blood. It's connected with the slow dural diurnal changes in blood pulsation, but as well rapid one, very, very quick, according to the heartbeat. So finally, we have the ocular pulse, which is a signal, and ocular pulse amplitude, which is differences between the systolic and diastolic pressure. So it's this rapid movements of the cornea. It could be observed and measured with the ultrasonic heads. And as I mentioned, when we try to find the signals in frequency, this signal of the movement of the cornea are covered by blinking, pulse, breathing. So these signals really influence the eye. So the cornea, maybe eye, can move forward and backward. Probably the cornea, it's the horizontally change shape with the increasing, for example, IOP, and let's say ideally it will be if we will take all this movements. It's the closer to reality. Okay, and this ocular pulse amplitude, as I mentioned, systolic, diastolic, and difference between them. And for the healthy eyes, it could be 2 millimeters of mercury, even 4. I can say that, for example, for glaucoma, it's more or less, but these changes are different during the day. Okay, so this dynamic change biometry of the eye. If biometric, so the optical system as well. And for example, during the increase of intraocular pressure, the eye could stretch, right? If it's stretched, the focal length increase, elements of the optical elements of the eye move. So, but we still see okay. So it means that the focal point is still at the retina. Even the patient with glaucoma with high intraocular pressure, they can feel headache, but they don't mention that they don't see sharp. So retinal image quality depends on the integrity of the optical system and ocular dynamics. So we have the effect of sometimes self-adjustment of the eye. So optomechanical integrity compensate the changes in IOP and biometry without loss of sharpness. And it could be some, for us, we use that verification of the material properties of the mechanical model which we proposed. So, of course, this hypothesis requires a combination of parameters, and its biometric data, mechanical properties of tissue and optical components, and boundary condition, which I mentioned that it's simplification as well. Each model has some assumptions for that. So to conclude, for optical reason, both geometric and material parameters must meet strict conditions. And it's idea for it was idea for verification of our model. If I mention about the sharp image at the retina, I should to explain what I mean. So we assumed spot diameter as the criteria for image quality, and it was refractive error less than 0.25 diopter. The spot diameter less than 40 micrometers correspond to that plus minus 0.07 of millimeters of defocus. This model assumed the contour of wide field schematic eye with these parameters, and simulation were made in Optics Studio ZMAX. So, as I mentioned, all elements can move during the increase of intraocular pressure, and this model includes few elements, few different neurological regions, as the cornea, limbus, sclera, zoneless lens, and average, let's say, extraocular tissue. So it's everything around the eye. Fatty tissue, muscles, just the average region, rheological region. So if we have this geometry, move to the material model. As I mentioned, it's a lot of different propositions, and in the literature, mostly elements of the eye are modeled with hyperelastic and elastic materials of different types, and different types has different material parameters, and which one we should to pick depends of course of applications, but how to verify it. So we assume this optical verification, and it's secure that we can find a set of material properties to fulfill this hypothesis of mechanical integrity, and obtain with increase just in physiological range, for example, this ocular pulse, to obtain the defocus less than 0.07. Why this kind of model is important? Because we have hyperelastic, but it's Ogden one and now Hogan. It changed the displacement of the model. For example, Ogden model, the distribution of displacement are concentrated in the center of the cornea. So it's changed shape of the cornea, geometry. So you see a radius of the cornea, you see a radius, so the refractive power. And it's clear that for 20 millimeters of mercury, this defocus is higher than 0.07. But when we take the Neo-Hogan model, occurred that the distribution of the displacements concentrate on the periphery of the cornea and limbus, so make some kind of ring around the cornea to keep more or less constant shape of the center of the cornea. So probably the radius will not change as much. And finally, for even 20 millimeters of mercury, this defocus could be in the range of 0.07. What about the geometry of limbus and extraocular tissue? So, geometry of the limbus, if we extend the this rheological region, we will obtain the defocus more, so it's increased with increase of the geometry of the limbus, and reduction of this area give us decrease of defocus. And geometry of the extraocular tissue is important as well, because the reduction for 30 and 50% gave us different results, but still a reduction for 50% is in the range less than 0.07 of defocus. So this parameter is not as much important or not as much significant for verification, optical verification. So it was just general look how the different parameters of the model changed optics, and this optics could be some kind of verification, of course, theoretical. The best verification will be in vivo, but it's more difficult. So biomechanics of the cornea. Commonly model because of different procedures, ectasis of the cornea, and actually it's first element of the eye and most important for optical power of the eye. So shape of the cornea, which is crucial for eye power. It's some kind of equilibrium between the intraocular pressure in the anterior chamber of the eye, mechanical stiffness, mechanical behavior of the cornea, which is connected, of course, with geometry, with the tissue, mechanical parameters, and thickness, and external forces. So for the physiological modeling, it could be atmospheric pressure, but when we want to simulate, for example, tonometric methods, it could be some air path or different forces. And the distribution of this parameters is different. So in the cross section, we observe a lot of asymmetry in the cornea. So temporal and nasal side of the cornea is different. The temporal side is steeper, nasal side is flatter. So the radius is different as well. Changes from the center to the periphery of the cornea of the radius is different as well. Thickness distribution, according to that, is different, but this effect is not so as much as radius. So all these parameters are a reason why the approximation of the shape of the cornea is difficult. So in these models, mostly the simplification is connected with the approximation, finding the proper geometrical shape for the cornea. Of course, it's connected with the structure of the cornea, most important for biomechanics. So, cornea includes 6 layers, and the thicker one is stroma. more than 90%. Stroma consists lamellas. Lamellas consist fibrils, and fibrils collagen fibers. Fibrils. So the distribution of the collagen in the cornea is different. And in X-ray scatter, we can notice that the more collagen is in the periphery of the cornea and in the sclera than in the center of the cornea. It's nothing surprising because the cornea is thinner in the center. But what is interesting that it's not symmetrical in the eye, but it's some kind of rhombic shape. But we observe symmetry between two eyes. And based on this data, kind again of the ring. As I mentioned, that this ring of the cornea, so limbus, it's very important for optics. It's a proof for anisotropy, mechanical anisotropy of the cornea, very difficult to model. And this mechanical anisotropy corresponds with optical anisotropy. And in polariscopic images of the cornea recorded in vivo, we can observe a very similar rhombic shape. I will not talk about optical anisotropy because it's different, very long lecture. But just I wanted to show you that mechanics and optics correlate each other in the eye. And according to all this information, we should do big mechanical model of the cornea. So as I mentioned, mostly it's hyperelastic models and viscoelastic models. With hyperelastic models, we can take into account anisotropy connected with distribution of the collagen, stress under physiological conditions, because physiologically it's no zero pressure, but average 60 millimeters of mercury. Typical strain correspond to finite strain hypothesis. Non-linear behavior. Non-linear behavior, I mean the material characteristic of the corneal material, strain, stress, and non-linear relationship. And for on this graph, it's 3 humans corneas in different age. So we can see that this material parameters change with age from this one to this one. So this change occurred that the cornea with age is more stiff. And this one for person eyes. And in case of person eye, the characteristic is more linear when we compare with human cornea. It's probably connected with that big cornea is 1 millimeter of thickness and doesn't change from the center to the periphery. So the thickness is constant. So it's non-linear behavior and higher water content, so incompressibility of this material. But cornea is viscoelastic as well, so this viscous elasticity take into account time dependent response of the cornea to the forces which work on that. So on this video, probably this one. On this video, we observe natural blinking and forced not blinking, which in case of no blinking, the primary upper lid change the shape of the cornea, which is associated with astigmatism. It's very short effects because it's few seconds when we cannot blink. And again, after blinking, with some time, the cornea changes to the back to the initial shape. So it's proof that cornea has some viscous elastic behavior. And this effect we can observe during reading. We don't blink so frequently as during the reading, so the cornea changed the shape, or upper lid changed the shape of the cornea, and observe the highest positive change and negative change on the part of the cornea. And according to the literature, 2 hours of reading can change the shape of the cornea in this way that we will produce the 2 diopters of refractive error, or astigmatism. So it's one effect. So the lid, the upper lid, squish the cornea. And the next effect during the reading is the effect of eye movement. So it's just help to the upper lid to change the shape. So the cornea distortion increased. And what is interesting, or just show this viscous behavior, is that recovery to the initial shape take next 2 hours. So the time is recovery time is approximately equal to the duration of the near task. Very important for myopia, for children, for example, work too much for the near task. This can change the material properties to some. So let's say in the childhood, not in the adult life. So from this, of this 2 hours after reading, we need 1.5 to 2 hours to back to initial sleep. So this viscous elastic properties of the cornea, actually it's nothing new. In 1937, Friedenwald as a first described the corneal viscous elasticity. Nyquist in 1969 confirmed these behaviors in ex vivo experiments. Then Wu in 1972 proposed the first mathematical model of the corneal scleral shell. And finally, Boyce in 2007 proposed the first biomarker for mechanical biomarker for the cornea, which represent the viscous elasticity of the cornea. And actually, from this time, the development of ocular biomechanics became important in clinical use, mostly in tonometry and methods of tonometry. So we have the two methods of measurement of intraocular pressure, which are commonly used in clinical practice. One is gold standard in ophthalmology, gold monoclonal tonometry, where the tip of the tonometer put the force on the central part of the cornea to flood this area on the diameter 3.06 millimeter. And this pressure, this force working on the area, so pressure outside which we need to flood the cornea is the equal the intraocular pressure inside the eye. This method needs few parameters to work very good, and actually from the mechanical point of view, it's working properly for the pressure to maximum 24 millimeters of mercury. The problems with underestimation, overestimation occurred for the high pressure, and it's again problem because we should to diagnose the patient with glaucoma. And RPAF tonometer commonly used because it's quick. We don't need any drugs and quicker. So during this measurement, detector record the intensity of the light beam reflected from the cornea. And so actually, according to the tonometry methods, to this time, we take into account the changes in thickness between the patient. But in terms of tonometry, maybe we should to consider the cornea as a thin, thick, but as well as a soft and stiff. Of course, thickness indicates bending strength of the cornea, but resistance during the applanation depends on thickness and mechanical parameters of this tissue. So from the viscous properties which show us how long or how much time the cornea needs to back to the initial state. So during this RPAF measurement, the full corneal response started from this figure. Include the first applanation, when the cornea is flattened with the arclet. The cornea started deform, obtained maximum deformation, and then started to back to the initial state, going through the second applanation and back to initial state. And this full response of the cornea was used in the corneal response analyzer, which as first equipment show hysteresis as the biomechanical bio. And so on this graph, the green line it will be pressure from this instrument, and the red line is the intensity of light recorded by detector. So at the beginning, we start from very small, low pressure from the equipment. Nothing happened with the intensity because the cornea is initial state, so the light reflected in different directions. Then increase of pressure from the instrument and the fierce applanation. So the cornea acts as a flat mirror, and we observe the maximal light intensity. Then still increase pressure of from the instrument. The cornea deform. So again the intensity of the light is low, and from the highest concavity, cornea started back to initial state, and we have the second applanation and the end of the measurements. It takes only 30 seconds, so it's very short time and short response of the cornea. So actually all tonometers, pair-path tonometers, use only half of this response, so the fierce applanation. And with ocular response analyzer, we have this two pressures. So the height hysteresis is a difference between applanation between the intraocular pressure in the first applanation and the intraocular pressure in the second applanation, and it represents energy loss due to the viscous damping in the cornea, and it's information about the dynamic condition of the corneal structure. Second biomarker is the corneal resistance factor, the coefficient of resistance of the corneal tissue for the forces which act at the cornea, and actually represent viscous and elastic properties of the cornea, describe the strength of the cornea. And in this equipment, we have two intraocular pressure. One is Goldman intraocular pressure, which is average of the two applanation pressures, and corneal compensated intraocular pressure. It's the formula which shows difference between the pressure in the first and second applanation with constant factor, which is calculated from the population screening. And both these parameters, hysteresis and corneal resistance factor, are reduced in corneal ectasis as keratoconus and in glaucoma patients. So for healthy cornea, the signal from ocular resistance analysis is regular. The differences between corneal compensated pressure and Goldman pressure is both of them are similar, so the difference is low. But for keratoconus is noisy signal, and according to that low probability of this measurement, higher difference between two pressures and low value of hysteresis and corneal resistance factor. And the keratoconus in different states, so it's even difficult to observe the one peak. These two biomarkers occurred quite good for the assessment of normal tension glaucoma, which is very difficult to diagnose. Oh, it's here because the pressure from the second applanation is significantly lower than the first applanation. And according to that, these two parameters are lower than for higher tension glaucoma, and for healthy corneas. And we can explain that, but that normal tension glaucoma patients show reduced corneal viscoelasticity behavior. And the next instrument with the biomechanical factors, it's a Corvis tonometer with shampoo camera. We can observe this in the horizontal cross section, the dynamic of the cornea during this measurement. As you see, it's healthy cornea and keratoconic eye, and this response is different. And of course, if we see something as this video, we can imagine ourselves that something happened. And in ophthalmological diagnostic, the measurement for healthy eye, and this most important state doing this measurement. So first applanation, highest concavity, second applanation for the healthy eye, glaucoma. It's higher tension glaucoma, so we don't observe the deformation, obvious deformation of the cornea in highest concavity, swollen cornea, and keratoconus. The response of this cornea is significantly different. So in this system, the parameters describe the deformation response, and this parameters it's a lot of, so I will not talk about all of them, but we have the length of the applanation in the first and second, highest concavity, radius in the highest concavity. All these parameters change with time, and as I mentioned, the measurement is only 30 milliseconds. In this instrument, we have different parameters than hysteresis and corneal resistance factor. We have BIOP, which is biomechanical compensated intraocular pressure, and should be used as a true intraocular pressure because take into account dynamic of the cornea. So this Corvis biomechanical index, which take values from the 0 to 1, show the ophthalmologist the dynamic condition of the cornea. So if it's low, it's green, so it's okay. It's red, it's not healthy, or maybe not healthy cornea. I can say that like that, but this response is different than in normal cornea. And standard parameters for screening. I will not talk about all of them because I know that time, Agnieszka, from time it's I talk too much. So this biomechanical corrected intraocular pressure. Why these parameters could be better than golden tonometry or different tonometers? Even I can say that tonometers, but this I want to say about biomechanically compensated intraocular pressure, because at first, take into account age of the patient. It's very important in biomechanics, because age-related variation in the tissue parameters and variation in central corneal thickness across patients. So again, this measurement it's more personalized for the patients. And next two parameters, stiffness parameter, which qualify corneal resistance, quantify corneal resistance to deformation. It's difference of pressure from the first applanation and BIOP divided by deflection. And relational thickness parameters, which describe how the thickness of the cornea, the changes in the thickness, changes from the thinness to the from the thinness in the center to the periphery influence the measurement of intraocular pressure. And sorry. So the lower thickness parameters indicate softer tissue, and it's higher risk for corneal ectasias. And in keratoconus, this approximational thickness reduced to the thinner cornea, central cornea, and higher progression of them of this ectasis. So, as I mentioned, mechanical properties, geometrical properties are connected to each other. So, so if we will have or if we will take into account the parameters from the response of the cornea, so dynamic response, and tonometric parameters from Pentacam, we have the full information about cornea. And to this time, I think that is the full diagnosis for keratoconus. So from dynamic response, we have the corneal biomechanical index. From topography index, which show the condition of the shape of the cornea. From the Pentacam, we obtain the shape of the anterior and posterior cornea. So it's more information than from topographer based on the placido disc, for example. And combine this two, finally, it's biomarker called topographic biomechanical index. Why it's important? What we can see. So it's healthy cornea, but for keratoconus patients, this biomarkers will be too high. So it's obvious diagnosis. Of course, this keratoconus we can see from only topography, but for early stage, this full diagnosis is very useful. And for example, refractive surgery qualification, and it seems to be that for this patient, these dynamic parameters are proper. This dynamic condition of the cornea is fine, but for topographic, something is in the middle, let's say. So finally, this patient will be not qualified for refractive surgery. So it's this benefits from the biomechanics for patient. But if we have so many parameters, they can support the effectiveness assessment of the effectiveness, for example, of cross-linking for keratoconus, and it's a signal for before cross-linking, after cross-linking, and very short during the cross-linking. We want to observe that cornea became more stiffer. So in this software, we can obtain the material characteristic for this tissue, stress, strain, and from this index to get information that the success of this procedure. So in this case, the characteristic moved to point B, and cornea became stiffer. It could be not so good, let's say, and cornea became softer. So it's obvious biomarkers for ophthalmological use. And the new parameter for normal tension glaucoma, as I mentioned, is connected with the lower viscous elasticity of the cornea in this case of the glaucoma. So it's novel approach for detecting normal tension glaucoma independent of IOP. It's very important in this case, and I think that it could be good parameter for glaucoma screening, but still actually this parameters is under investigation. So to conclude, I would like to show how this biomechanics support ophthalmology on this state. So each eye is unique, and taking into account these biomarkers, that the optimization of treatment is possible. Glaucoma risk assessment, tonometry adjusted by biomechanical parameters is this PILP. It's parameter for normal tension glaucoma diagnosis, early keratoconus diagnosis, estimating cross-linking effectiveness, and qualification for a refractive surgery. It's only symbols where this biomechanics could work and why people need this knowledge. So it's my conclusion of this lecture, and biomechanics of the eye is interdisciplinary field to build collaboration with different experts. So we need optics, we need mechanics, so we need ophthalmology. So just to construct a good mechanical model of the eye, we should to take as much information as we could, and of course, patient for not theoretical verification, as I show in case of optics, but as well from experiments and patients. It's the team which makes some research which I showed during that presentation. So as the last word, I hope that I convinced you that biomechanics, it's not only formulas, not only numerical models, not only things which we made for publications, but it could be, it could work for people as well, and to support early ophthalmological diagnosis, which is most important now. Thank you. We have time for questions.
Thank you for that nice talk, and I appreciate the acknowledgement of the importance to have interactions across disciplines to advance the science of care. One of the things that's always fascinated me, particularly in refractive surgery, is that we can remove so much material, and yet, you know, everybody was worried in the early days what's going to happen 20 to 30 years later. So to me, I was fascinated. We have different disease processes that dramatically affect it, but yet we can go in and remove a huge amount of material and have little effect. Do you have any comment on that?
I can say that I'm fascinated as well. But actually, I think that still biomechanics has to be developed to have the answer for that, and to observe patient for so many years. But I think that in this stage, the future of the biomechanics is exactly the prediction of the aging of the eye, prediction of the effectiveness of some therapies, and risk factors for some disease. And I didn't talk, I mentioned only about the myopia, but it's the biggest problem now over the world. So I think that the new biomarkers will bring the answer for the risk factor. But I'm fascinated as well.
I just have a quick question. You mentioned about myopia control and you know, when reading the effect that has on the cornea. And I was thinking, you didn't go into it, and I understand it might be a big topic, but does accommodation next to the cornea is the first half. Sorry, then the second half of my question is, one of the methods for myopia control is also keratology, where you purposefully manipulate the corneal tissue to kind of simulate that hyperopic defocus. So would that also eliminate that problem, the corneal biomechanical movement in myopes as well? I don't know if that makes sense.
Yes. I have maybe not so much experience with myopia and biomechanics, but definitely the effectiveness of the keratology depends from the condition, mechanical condition of corneal tissue. So if we can measure the patient with all these biomarkers, we can predict the effectiveness of this orthokeratology. But again, it it's age related, or I can say like that, right? So we have to observe this patient, but it's not used in clinical practice. And another question about accommodation. Of course, the accommodation change biomechanics of the cornea, because during the accommodation, optical system, optical elements move as well. And sometimes there's that we have different types of accommodation, actually, different ways. Each eye is unique. So for some patients, accommodation is connected only with the lens. So the lens is thicker or thinner, right? And depends from biomechanics of the zonules. But for another patient, the changes of the cornea is maybe of the lens. It's significant, but as well we observe movements of the elements. If it's movement element, so probably the shape of the cornea is changes as well. So, but still it's under research, so I can just move you to the some publication connected with the lens and accommodation. But it's a lot of them.
Thank you so much, Magda. All right, the good news is it's lunchtime, and if we can come back at 2:15. 2:15.